All right, let's start. Hello all, and welcome to the Sudanese Infectious Disease Association Grand Rounds. It's my great honor to introduce our distinguished speaker today, Dr. Taha, Tahir Taha. Dr. Taha is a professor of epidemiology at Bloomberg School of Public Health at Johns Hopkins University in Baltimore, Maryland. With over 35 years of experience in the fields of epidemiology, population health, and infectious diseases, he brings a wealth of knowledge and insight to our gathering today. As a physician and researcher, Dr. Taha has been at the forefront of critical advancement in public health. He previously served as the co-director of the Infectious Disease Epidemiology program at Johns Hopkins, and he currently holds the position of Principal Investigator and Director of the Malawi Clinical Trials Unit. This important research collaboration funded by the U.S. National Institutes of Health encompasses a network of esteemed institutions, including the Kamuzu University of Health Sciences in Malawi, alongside 5 global research networks we all know as IMPAACT, HPTN, ACTG, HVTN, and MTN. For nearly 3 decades, Dr. Taha has led in significant observational studies and clinical trials focused on the impact of HIV/AIDS in Africa, exploring effective interventions to alleviate the burning disease among vulnerable populations. He also has also directed numerous training programs aimed at empowering African scientists and enhancing local capabilities in education, research, and health services. Dr. Taha's extensive publications in peer-reviewed international journals reflect his dedication to advancing global health and infectious disease research. He has successfully raised and managed multi-million-dollar grants to support and sustain important training and research initiatives across Southern and Eastern Africa. Today, we are fortunate to have him share his insights and experiences with us. Please join me in welcoming him. And Dr. Taha, the floor is yours.
Shukran, Izzeddin. Thank you very much. Thank you very much, Dr. Izzeddin, for the generous introduction. I wanted to welcome you all, and really glad to be here. And I thought I will share with you what I have come to learn and how I got started. But by all means, if you find me mentioning myself, never intended to be. It is just I wanted to introduce the work that we have done. So before starting HIV, I actually did some work in Sudan. I shouldn't say before, but I tried to do a few things in Sudan, and some of these are listed here. And I trained in malaria. Actually, my thesis was on placental malaria, and I collected the placentas from so many cities in central Sudan. I just wonder today where would it be from Shukaba, just next to Wet Madani, all the way to Haj Abdullah, Sinar, Mairno, and all these places up all the way to Sinjar. So we did some great work there, and I thought I would continue the collaboration, but despite all my efforts and also going there through doing training and trying to build collaborations, it didn't succeed well as we have done in Southern Africa. So I actually wanted to discuss this slide with you at the end, and I thought I might not find time. So I thought we'll just get started with this. And some of my comments are personal, but definitely if you are interested in this area, I am available to share with you more. So how did I get involved in HIV and with Malawi, where I spent more than 30 years? I actually lived there for 5 years with my family from 92 to end of 96. Some beautiful 5 years. And if it hasn't been education for children, I would have probably stayed there longer. So how did I go there? I went there quite serendipitously. The director of our program at that time, every day will mention, Taha, you need to go to Malawi. So I said, I can go anywhere in Africa other than Malawi, because at that time, South Africa was still under the apartheid regime. It was closed to Africans. And like any Sudanese, we have never had we never took time to go to, for example, Southern Africa, or know what is happening in the countries of Mozambique, Zimbabwe, and so forth. I think we never went south. So I was very reluctant, but under pressure, I agreed to go there for 6 months. And the 6 months became 6 years, 12, 18, 24, 30, and counting. So that is how I got started there. HIV was just beginning. That was 92 when I went there. And HIV was really taking its toll at that time in the different populations in Southern Africa. So I wanted to share with you some experiences and some challenges. And you know these very well, but I thought I will just tell you over these years what has worked and what did not work. So as you know, patience, stability, and time is important. We were just talking about Sudan and Dr. Al-Fahal and how he lost his the investment that he has done over so many years. I will tell you a story about stability. When I went to Malawi in 1992, I opened an account in a commercial bank in Blantyre, one of the cities in Blantyre in Malawi, in southern Malawi. I opened an account there to receive funds coming from NIH or from Hopkins, and that was the main channel through which I received funding for the work we have been doing. That was 92. Today, that account still exists, and through that account, we still fund our project in Malawi. So that is stability. One way of just giving you need a stable place, and time and other things will come along. Building collaborations, talk to people other than people with whom you work. Explore some other disciplines, biostatisticians, the basic sciences. So I found that very, very useful. And actually, we were compelled, or we have to look for it. I have great reservations about our training in the medical school. The clinical part was wonderful, but our basic science training is deficient in so many areas. Things like, I mean, immunology, genetics. So you know about that. So all that I have to come and learn from the beginning. So, but collaboration. So you have to bring people, be that neonatologists, people who know biostatistics, people who know clinical trials. Of course, all the clinicians, you need them, depending on what you are doing. In the international setting, in particular, building infrastructure is very important. It is very difficult to invest your time and energy and develop a research project in a setting without providing training, without building physical and human resources part of it. And then finding funding. Just Dr. Izzeddin and I were chatting at the beginning here. How difficult is it to find funding? But anyway, I managed to find continuous funding for 32 years. So it must be possible, but it is difficult. There are so many areas where you can find funding. I listed few here, be that the National Institutes of Health. And the institute that will be of relevance to you is the National Institute of Allergy and Infectious Diseases. Dr. Morazo has replaced Dr. Fauci. a wonderful person. I have worked with her. She is an STI person. She knows HIV. She started in University of Washington in Seattle, and she was in Alabama. But she has been working, and we also did some work together on some strange things. I don't know if you know about bacterial vaginosis, but she is very much interested in in what is happening. Anyway, she values basic science, and she's a welcoming person. So there are RO1s, R21s, RO3. If you want to chat on this, I will give you my own disappointments and share with you how things get done. And 99% of what you submit will not get funding. So out of this, if you are able to get one or two, then that would be great. Other federal agencies, CDC, not that they are great, but they, from time to time, they have announcements. And then networks like the TB Alliance, the malaria people, they have their own network. So depending on your interest, you might be able to join one of these. And the industry, Gates, and Hatim is here. I don't know, WHO, I just put it there, but I think there are other agencies. If you are in academic setting, obviously you have to watch for your time, and you know the story about publish or perish, and deal with pressure. I mean, service, teaching, research, family, all these, they go together. And I found this quote, and always I try to remind myself whenever things don't work out. We have perfect data, observational data, to do a clinical trial, and then we implement the clinical trial, or we conduct the clinical trial, and the results come out to be disappointing. So this is a British. He is listed as an anatomist or anthropologist, but he has this great saying: "The great tragedy of science, the slaying of a beautiful hypothesis by an ugly fact." So when you do a clinical trial and it doesn't work, though, you can just imagine the disappointment, and you might not even be able to publish what you have done. So I just wanted to get these two slides out before going to. So as again, I can't move this now. Okay, that's it. So let me try to move this. So what I will overview or share with you, basically a general talk. It is diverse topics, not a single area. And it is a survey of the past, what we are doing now, and what is for the future about HIV. Okay, so HIV is actually still a real problem. So an estimated 39 point, and this is WHO figures from last year. So this is very current. So an estimated 39.9 million people living with HIV. That is the data from as of 2023. And approximately 2/3 of these 40 million, they live in Africa, actually. Most of them are in Eastern and Southern Africa. The areas that are covered with clade C, that is where most of the problem is. And 1.3 million people were newly infected with HIV. So as you can see, the rate of acquisition is not trivial. And the rate of acquisition actually came down tremendously. It was 3.2 million in 1996. 30.7 million are accessing ART. These are real successes, up from 7.7 in 2010. But it's still short of the 34 million. And so you can see here how much the difference could be. And treatment is actually, women access treatment more than men. As far as mortality, 630,000 people died from AIDS-related illnesses worldwide, compared to 2.1 quite substantial in 2004. The target for 2025 is 250,000. So as you can see, the numbers are still very big, but we have made real progress. I will be talking about Malawi, so I thought I will just give you an idea where Malawi is. It's a small country here in Southeast Africa. From the north, there is Tanzania, and from the west, there is Zambia. And the whole country is actually landlocked, and it is sitting inside Mozambique. The capital is Lilongwe, and the place where we work is Blanta, a beautiful city in southern Malawi. So this is where our project is, the Johns Hopkins Research Project. And Lake Malawi takes about 1/3 of the country. And I invite you all to come to Lake Malawi, very nice resource. And you will meet also some people. It's a wonderful place. If you want to write a book or just have a rest for some time, come to Lake Malawi. It is very accessible, actually. I mean, from South Africa or from Addis, flights are there every day. So I spent most of my professional HIV career in this area, prevention of perinatal HIV transmission, vertical transmission. So most of the slides I will present will probably focus on this. This is when I went to Malawi in 1992. You can see where we were as far as seroprevalence of HIV. So you can see here, this is among pregnant women. 1/3 of the women who were coming to the antenatal clinic were actually seropositive. So you can see here the seroprevalence over time. And we used to do the seroprevalence testing for the Ministry of Health every year. So you can see it was really a big problem. One note about these slides, these are the original slides I made at the time. Any of these slides with dark background actually comes, these are very original. In the old days, we used to take the data and go to the Department of Pathology. They have medical illustrations, and that is, they will do the slides for you. There were no PowerPoint slides. So these are the original slides. Okay, so it is not only Malawi. This is HIV prevalence among pregnant women attending antenatal clinics in sub-Saharan Africa, 1997 to 2007. So you can see places like Botswana, Lesotho, Swaziland, which is now called Eswatini. You can see how high the seroprevalence was among pregnant women, 40% or 30%. So Malawi was not alone, but all the countries in that region, of course, don't forget South Africa. You can see the black line here. So these countries had high seroprevalence until very recently, actually. And this is seroprevalence in Eastern Africa. During that time, Ethiopia and Kenya, they were relatively low. And the lowest rates were actually in West Africa. You can see here, Burkina Faso, Cote d'Ivoire, Ghana, Senegal. And HIV prevalence has been low and it remained low. And you can hypothesize why. This is data from South Africa. This is HIV in pregnant women in rural South Africa. This is data from the area of KwaZulu-Natal around Durban. Durban is on the Indian Ocean. So you can see here the HIV prevalence. Up to 50% of the women, of young women, are HIV infected. And by the way, I need to change my language. We never say HIV infected today. We say women living with HIV or pregnant, or people living with HIV. So if you find it on these slides, it was acceptable then, but right now it is not. So if I say HIV infected, I should be saying people living with HIV. So you can see here how common HIV has been. However, there are stark disparities in HIV prevalence in male and female high school students, between men and women in Southern Africa. And this is high school students in rural South Africa. You can see by 20 years, about 25% of these girls would have been HIV infected, okay? It is lower among boys. You probably heard about the sugar daddies and the stories that go with that. Why girls get infected? Probably they are having partnerships with male partners who are much older than them for various reasons. But this is again from KwaZulu-Natal in South Africa. And still to this date, the HIV prevalence is very high in the area of KwaZulu-Natal. So that is where most of the infections are occurring in South Africa, despite of the great work and the intervention that has been done. This slide summarizes the natural history of HIV in children. So this is mortality and HIV disease classification by age in HIV-infected children. This is from our own site. I think I prepared this slide in 1993 or so. So let me so these are survival curves. So if we took, for example, a group of children who were infected at birth, or just say at 6 months, and we followed them for 3 years, what would be the outcome? All what I'm saying here is before the introduction of antiretrovirals. So at that time, none of the antiretrovirals were available, or none of the of what today we give to women, or even the zidovudine regimen that was discovered in 1996 here in the US. At that time, it was not available in Malawi. So these are antiretroviral naive populations. So you can see here, you start, this N refers to normal. This is a CDC classification. So by the time you reach 3 years of these HIV infected children, only about 1 or 2 of them would still be normal. B is moderately sick. So you can see this group is probably 3-4% by 3 years. And then C is severe disease. You can see about 1 or 2% of them will have severe disease, but the majority, 87% or so, would have died. So this is data from our site. This is what has been happening at the time. So these are also survival curves. You can see overall mortality stratified by the child HIV status. So children who were born to women living with HIV, and at that time, again, there was no treatment, you can see their survival is very poor. So by 3 years, about more than 50% of them, or about 50% of them would have died. How about those who were born to women living with HIV, but the child, he or herself, was not infected? So it is this group B. So you see their survival is actually very comparable to the first one, these red dots. These red dots are children born to those who are not infected. So the survival of those, of the children born to HIV infected women, and those who are not infected, born uninfected, and also mother is not infected, so their survival is very comparable. So very early on, this is also from 1993, very early on, we knew what the problem is. We just were out of ideas how to bring this survival to be comparable to this one. So we knew the problem. However, the means of preventing the transmission was not in our hands. This is HIV infection risk while breastfeeding. You know that transmission of HIV can happen at 3 points, either intrauterine, while the woman is pregnant, or intrapartum, that is very late pregnancy and during the process of labor, and then postnatal, and that is mainly through breastfeeding. I don't need to tell this group that breastfeeding is really important in Africa. We can't counsel women not to breastfeed. So that is, breastfeeding is really the survival. And at one point we were discussing actually die of HIV or die of gastroenteritis. So it was a conundrum when WHO at certain points made recommendations which did not fit the situation, the field situation. So let me show you the risk of HIV for a group of, so this is a group of children that were not infected at birth. So we did PCR and we excluded those who were infected at birth. So those were most likely infected intrauterine or intrapartum, and those were excluded. So we started with children at 8 weeks who were not infected. So at that point, they were not infected. However, they were born to HIV-infected mothers. So the red line here shows you the rate of acquisition of HIV. So you can see the rate here, and the blue lines are the 95% confidence intervals. Most of this transmission, so let me say first that by 24 months, about 10% of the children got infected due to breastfeeding. And most of this transmission occurred during the first few months. So prevention of HIV transmission through breast milk is we spent so much time on that, and so many clinical trials we did, and I hope I get time to review those. All right, so this slide is actually very, very important, and one of the best I can show to anyone to tell the story, how successful we have been, and our colleagues. So when I say we have been, I definitely mean colleagues from Malawi with whom I have been collaborating, and also from other parts of Africa, South Africa, Zimbabwe, Uganda. So we have been working together, and we have been working together through these networks. So but this data is from Malawi, from our site. So the ICAR, or you see here, 89 to 94, this is the only observational study. However, all the others are clinical trials. And I had the privilege of being the principal investigator for these clinical trials. The rate of transmission was about 35% in the early 90s. So that is the rate of transmission, vertical transmission from an HIV-infected mother to her child, okay? And then I remember in 1993, the Ministry of Health in Malawi, they called me, they summoned me, and they said, Taha, you have been coming to us every year and saying HIV prevalence is so much, and things are this here, so many people died. So what are you doing? And what are you going to do? So I told them, I don't have, I don't have antiretrovirals. I don't have a vaccine. I don't have any, something that we can give to these mothers. So, and of course, the magnitude on males is also substantial. But anyway, starting from 1993, we became really creative, trying to find non-antiretroviral interventions. And by the way, we tried HIV vaccine so hard, and to this date, we have not succeeded. So I will not include HIV vaccine events in what I'm presenting. Actually, there is nothing to present about it. But it is our biggest network, and they are getting most of our resources, and we are not quite happy with that. But anyway, so they do exist, and they are doing wonderful work, but it is not working. So starting from 1994, we started to be very creative. So the WASH study, this is a landmark study. Although we were not successful with reducing vertical transmission, but it was the first clinical trial we did. And in this trial, what we did is we used, knowing that most of the transmission happens intrapartum, meaning during the process of labor, according to the literature, about 70% of the transmission occurs during the process of labor or during very late pregnancy. So we thought if everything is happening in the birth canal, how about cleaning the birth canal using chlorhexidine? As you know, chlorhexidine is used in labor wards all over the world, and even here in the US. So we thought if we used a broad spectrum solution like chlorhexidine, then every time the midwife is assessing progress of labor, she will put on, of course, she will be gloved and putting a glove, and will take a piece of cotton soaked in chlorhexidine. And while she's doing that examination, she will also wipe the secretions around the cervix and during and the birth canal. And by doing that, she will physically remove some of the secretions which will contain HIV, and also will leave behind some residual material. So that was the concept of this low cost. This cost 5 cents per woman. So that is what we did. And if you are asking what is the scientific justification for this, we had at least 2 justifications. One is that Scandinavians actually, they did this type of interventions to reduce group B streptococcus. So they did that type of studies. So we had at least precedent. The other thing is we did some innovative observational studies with twins, and we the data from twins actually gave us more evidence how this transmission could occur. I don't want to quiz the group, but whom do you think will get infected? The first twin or the second twin? So according to the literature and our own findings, it is the first twin. Apparently, the first twin does all the hard work. So it is the one that comes first, and therefore probably they do most of the hard work. And so based on that, on that evidence and transmission
Can I ask you a question? So
Sure.
is it so using this chlorhexidine to like just kill the bacteria because it facilitates the transmission of HIV, or what's the hypothesis here?
Well, both of them. We were not actually the bacterial infections that I will show you a few slides was a secondary outcome, but the primary aim was to reduce HIV transmission. So that was our justification. Anyway, this intervention, despite being innovative and it was covered very well, it didn't reduce HIV transmission. You can see the rate of transmission was 28%. So that didn't work. And then we had data, actually, women who transmitted or had vertical transmission had lower serum vitamin A during pregnancy. Very beautiful data. Those response, and so we had clear data showing that these women actually transmit HIV more than women with adequate levels of serum vitamin A. So we said, fine. I mean, we have the biological plausibility here. And then why don't we do supplementation with vitamin A during pregnancy? It didn't work. So you can see the rate here, 26.8%. So this was vitamin A supplementation. Actually, we did the study, we did the clinical trial, and simultaneously a group from Harvard did it in Tanzania and another group in South Africa. And all the 3 trials didn't show an effect. So this is one of those studies where you have all the evidence from observational studies, and then you do a clinical trial and it doesn't work. But both the WASH study and the supplementation with vitamin A had profound effect on other outcomes, be that the birth outcome or sepsis with MCH, with the washing with chlorhexidine, and I will show you a few slides. And then the era of treating STIs came around 1999, 2000. Everyone started talking about STIs, treating STIs, and then it would reduce HIV incidence. So we thought, okay, if STIs cause inflammation, therefore probably they attract those target cells of CD4 and other cells. And so we thought, why don't we treat infections during pregnancy? So we thought if we gave antibiotics during pregnancy, then we will treat chorioamnionitis, and therefore probably will reduce transmission. It didn't work. You can see here as well. But why is this 16% and this is, for example, 27%? Because here at this time, nevirapine, the single-dose nevirapine, was tested in Uganda in a study called HIPNET 012, and it became standard of care. So single-dose nevirapine, you give this single tablet to the mother, and then give a solution to the baby immediately after birth. And our colleagues here from Hopkins working in Uganda, they found that reduced transmission by 50%. So it can't be more easier than this one. So it became the standard of care. So the reduction here that happened is due to introduction of nevirapine as a standard of care. And then this is a study, it's called NAVAS, and we published these findings, and actually the references are here. So here, there is a phenomenon in Africa, and we gave it the name, and now it is actually used more often. We call them late presenters. These are women who left their townships intending to deliver in the hospital. By the way, hospital deliveries in Southern Africa are very common. So rarely do women deliver at home. So these women left home with the intention of delivering in the hospital, but on the way, due to difficulties with transportation and roads and all that, women bring their children or their newborns with them to the hospital. So this phenomenon or this type of deliveries, we call them late presenters. So therefore, even a simple nevirapine regimen, like giving it to the mother and giving single dose to the mother and single dose to the infant, even this one might not apply for women who come late because they wouldn't have received nevirapine. First of all, you don't know if they're HIV infected to begin with. And even if you said, I will give to every woman who comes, but still some women will come after they deliver. So we sort of a post-exposure prophylaxis. This is a study here. So how about giving, give the single dose nevirapine to the child, just like in the HIPNET 012, the nevirapine regimen, but also because they didn't receive the maternal dose, give the baby as post-exposure prophylaxis, give them zidovudine as a team. So for a week. So this study tested the post-exposure prophylaxis in children, and indeed it showed effect, a reduction by about 37%. So this is studied, and it was covered very well. And then, as I said, breastfeeding is a real problem or a real situation in Africa. And since we cannot tell women, even if they are HIV infected, do not breastfeed, because that will mean the baby will die with gastroenteritis. So we started thinking about how can we extend this single dose to the infant, meaning antiretroviral coverage for a longer period. However, we had no safety data. Even for things like zidovudine, we didn't have any safety data. we knew if you can give it as a week or so, that is fine. There were no concerns. But beyond that, our IRBs and everyone, they said, well, there are toxic effects and you don't have the safety data. So we said, we agreed, we will give it to 14 weeks. And why 14 weeks? Because this is the time period when immunizations are given in Malawi, so childhood immunizations. So we thought, okay, we will give it to, we will extend zidovudine for 14 weeks because the child is seen often, and therefore we will be able to see, to assess safety. And then based on this, we developed another study, extending it to 6 months, and this is this. This is this one up to 14 weeks, and then this is out of this same clinical trial. Some women started receiving antiretrovirals, very selective, very few. But among those women who received antiretrovirals during pregnancy, the rate of transmission became 1.8%, or at least we found that it is 1.8%. And this PROMISE trial is more recent, and this was a very large clinical trial involving sites from India, Thailand, India, Brazil, and most of the African sites, including our site, where women received combination antiretrovirals, at least 3 drugs. And the rate of transmission to the infant became 0.5%. So only 0.5% if the mother receives antiretrovirals during pregnancy, and continues obviously after that for their own health. So you can see from where we started from 35 to 0.5%, and this is where we are, 0.5%. Actually, if today we cannot find HIV infected children to include in our cure research program. The infection is very rare, but it is happening. And why is it happening? Are those individuals who are out of coverage? For example, women who do not know that they are HIV infected, or infections that happen, acute infections that happen during breastfeeding period or during pregnancy. So this is where we are, or the story of vertical transmission. Let me just show you a few slides about the benefits of the wash. This is the effect of cleaning the breast canal with an antiseptic solution on maternal and newborn morbidity and mortality. This was published in the BMJ. And you can see here, this is actually sepsis admissions. So during the months of June and July, we just followed or monitored what is happening. We didn't make any changes. So, and then during the months of August, September, and October, we implemented the intervention. And the intervention was basically every nurse or every midwife was doing cleaning with fluorhexidine, the way the protocol is written. And it's a very simple, actually, it's very simple for the midwives, because they do this all the time. And then after that, we stopped the intervention, and you can see here what happened to sepsis admissions. It jumped again. So it shows that actually this simple 5-cent intervention can reduce sepsis admissions. It also reduced maternal morbidity and mortality. So you can see here overall admissions much lower than during the non-intervention period, and it is statistically significant. The sepsis admissions, you can see much lower here, 1.7 to 5.1, and the overall mortality was much was comparable, and sepsis deaths were not there for both groups. So this simple intervention actually had very good benefits, and accordingly, organizations like UNICEF, the World Bank, they recommended it for globally. Some countries actually, to this date, they do it. They do it in Malawi, and I know it is being done in Congo, in Nepal. So it is a very simple intervention. There is nothing there other than a bottle of chlorhexidine. Of course, we have to dilute it. A bottle of chlorhexidine was enough to do this trial, and we left the rest and we brought more for the hospital. So it is not expensive, it is safe, and it didn't reduce HIV transmission. Of course, we didn't know at that time that transmission actually happens through it is the viral load. That is important, and you have to reduce that. That is the mode of transmission. And during the process of labor, as you know, there are very strong uterine contractions, and therefore transmission, if things are not controlled, transmission will be high. So this is vitamin A. I told you about the vitamin A supplementation. It didn't reduce transmission. You can see here HIV infection is not significant, but there were statistically significant improvements in infant birth weight. You can see the differences here. So there were our secondary objectives were met, but the primary objectives, as far as reducing HIV transmission, it didn't work. And then this is the work we did, treatment of chorioamnionitis. It was as I said, we tried to, because of all the emphasis on STIs, and that these inflammations, and probably if you treat the inflammation, therefore you will reduce transmission. So we did that during pregnancy, and it didn't work. So this was published, and this is the post-exposure prophylaxis I was explaining. So if you are interested in these articles, I mean, they're available. This is also one of the trials we did, and it was the second part of the Navazo study. And then the extended antiretroviral, we extended it to 28 during the breastfeeding, and it showed a 50% reduction. I didn't include here the Kaplan-Meier curves, but this was very well reported. And then really came the days of antiretrovirals. This study, it is called the PROMOTE study. We followed women who have been receiving antiretrovirals for 10 years. Basically, we want to see, first of all, safety. We wanted to measure adherence, and we wanted to see how are these women feeling. Are they feeling good? Are they, for example, their fertility is improving? So I was a co-chair of this protocol. It was done in 2 sites in South Africa. Let me just show you some of the. So it was published in The Lancet recently. So these are the sites: Kampala from Uganda, Blantyre and Lilongwe from Malawi, Harare, Seka North, St. Mary's from Zimbabwe, Durban and Soweto from South Africa. So these are 8 sites where we did this study. These are the numbers, but I wanted to show you this curve. So you can see here 3 bars. The first one is reported health status, whether the woman will say excellent or very good. She is feeling very good about her status today. And if, the second one is being unwell or visited a health center. And then the third one is she has been admitted to the hospital since last visit. So if you see the time we got started here, you can see here what happened at baseline. Still, the number of women who said they feel very good after using antiretrovirals for all this time, these years. You can see it's almost 7%, and it kept increasing. By the time we got to 4 years or so, you can see that this optimism and reports of being excellent and very good did not decline. Actually, it went up all the time. And what is declining is what you can see here, for example, be that unwell or being admitted to the hospital. So you can see these are in this direction, and this one is in this direction. So clear benefits the woman in their own feelings, they express where they are today. So, and what happened with pregnancies? This is quite remarkable. So these are number of women ever reported being pregnant during this study. By 4 years, we had 864 pregnancies. Our estimation from the beginning for budget purposes, we said we will have about 250 pregnancies during the entire study. We made that 250 actually during the first year. And by the time this study reached 4 years or slightly above 4, there were 864 pregnancies. So, and we even had seen women who had more than one pregnancy. So as far as fertility, be that biologically or just because they are feeling healthy, then there are no problems with fecundability. So as you can see, women feeling good, they want to compensate probably, and they are having pregnancies. The safety, very good. And I didn't show you the adherence. Is actually, the adherence is very good. This is viral load. And all the sites, it was more than 80%. So that is about long antiretroviral or antiretroviral treatment and where we stand today. So all the women right now are on antiretrovirals. Antiretrovirals are available. And almost all of them right now has switched to dolutegravir. And this is a universal treatment, dolutegravir plus DTG plus I think 3TC and TDF.
Prof. Taha, before you move on, I just have a question.
Sure.
I would like to I was just wondering why women are feeling good. Because what I understand is that these antiretrovirals do have some side effects.
Mm-hmm.
So what happens to this? Are the side effects decreasing with time, or what is happening?
Yes.
Can you elaborate more?
Yes. So this is, let me show you the safety. So this is severity of all adverse events by site. So most of these adverse events were either moderate or mild. You can see here, the life-threatening ones were very small, 2.4. But you can see here, what you could say severe is 37.5%. However, reporting of adverse events, it means all events. It doesn't distinguish between, if someone even died by a car accident, that is also counting. But things like anemia or things like any side effects you could think of drug associated, those were very minimal. So we have gone through this from the days of single dose nevirapine to 1 week of zidovudine. And then with most of these women, all the women actually, other than Kampala, in Kampala, they were using PIs. And in the other sites were efavirenz-based regimens. So the thing that, why, for example, switched from the efavirenz to DTG is due to this resistance. But as far as serious side effects, it is very minimal.
All right, thank you, that's clear.
Sure. So let me give you some idea about sexually transmitted infections. And I hope I still have time to go over some of the other things, but I think with Izzeldin, how much time will you allow?
No, I mean, we can go on if nobody, we can go for another 15 minutes or half hour even if you want to.
Okay. So let me just give you quickly a few ideas about STIs. STIs are very common in Southern Africa, even today. So these are data from the early years when I was there, actually. This is trends of STDs. You can see syphilis, trichomoniasis, gonococcal infections, genital warts, ulcers. The first time I see a chancroid was in Malawi. So if you ever see chancroid in an HIV infected individual probably will go off food for a few days. So STIs are very common, and rates have come down, but this is when we were monitoring it closely. But you can see it is really high. All right. So and it is higher among those who are living with HIV. So you can see here the rates are much higher. Be that syphilis, trichomoniasis, gonorrhea, and genital warts, and likewise genital ulcers. It is not a typical STI, but one of the conditions that I personally spent some time researching this is bacterial vaginosis. So it is a disturbance of the vaginal pH. As you know, an acidic vaginal pH is protective. And if for whatever reason, and there are certain cultural practices that are adopted in some of these communities that increases the vaginal pH because of use of traditional medications. So we saw this could be what is increasing rates of acquisition. So we did several studies, and one of the reports we did that received much attention is the association of bacterial vaginosis with HIV acquisition. So this is this was the original publication, and our colleagues from Uganda also reported with association of bacterial vaginosis with prevalent HIV infection. So we were one of the early sites to report acquisition of HIV associated with bacterial vaginosis. And you can see here the association with bacterial vaginosis, 3+ here. We use 3 clinical criteria, and it is here. I didn't refer to it, but it is vaginal pH greater than 4.5, vaginal discharge, presence of clue cells, and positive amine test. So based on these clinical criteria, you can, right now you can do more molecular diagnoses. But based on bacterial on the clinical definition of bacterial vaginosis, you can see here the rate of acquisition. The odds ratio is 3.68 with a p-value of 0.04. After adjusting for all the other STIs, BZAD, gonorrhea, trichomoniasis, number of sexual partners. So this was one of the earlier reports. And if you are wondering what is happening with condoms in Africa, African men are very stubborn. And I said this many times and I got in trouble. So it never increased. I even took colleagues with me from here, from Hopkins here, who had studies in Thailand where condom use became 100%. They went with me to Malawi so that we can develop these programs, but it never increased beyond what you see here. 1995, it was still 5%. Means that men who are married to women living with HIV or not. So it doesn't work enough. So let me give you a few, let me review quickly a few studies about one of the problems in Southern Africa, and I'm sure it could well also be true in Sudan. It's just that we do not have data from Sudan. Is that woman-controlled interventions? Women have low. They cannot negotiate sex or negotiate how many children to have. Even family planning or use of contraception. So there is a quite imbalance between men and women, and this leads to problems. If a woman is using, for example, even to this date, we have women who came to our clinics 10, 15 years ago, and we tested them, we counseled them, we encouraged them to talk to their partners, They are receiving antiretrovirals, but they are hiding it from their partners. So it is just that situation. So they don't have, they are not empowered to discuss these issues with their partners. So development of women-controlled methods of prevention is a high priority. And one of these has been development of a ring. This ring is similar to what previously was used for family planning. So the ring, however, is coated with an antiretroviral. It is dapivirine. Dapivirine is similar to nevirapine, NNRTI. And so we tested this ring. It was a large multi-country, and you can see from the authors here, you can see how many people were involved. We tested in Uganda, Malawi, South Africa, and Zimbabwe. Actually, this ring, you can replace it or you can use it for 28 days. So it is, and the man will not notice the ring. So the woman can take it out, clean it, and put it back. And the effect of this coated antiretroviral is about 1 month. So we tested this ring, and it does work. It reduced transmission by about 27%. If you are saying 27% is little, wait until you see what we are hoping for HIV, HIV vaccine. We said even 20% we are willing to take it, 15% we will take it, but it didn't happen. So this ring is now approved by WHO, and it is, I think, about $6. It is used monthly it costs about $72 a year. So it is included in the WHO essential medications. So it is now being marketed and it is available. So,
before you move on,
yes.
I'll just like to ask about the vagina ring. And I'm just coming from a social behavior background in health. So I was wondering what could be the motivator for the women to use these antiretroviral? Are they meant to prevent infections to the women themselves or to their partners or both?
Oh, well, this is for, so the study was done among HIV uninfected women. So they didn't have HIV when, so these are uninfected women using the ring. And then what you do is to put them 2 arms, women who are using the ring and women who are not using the ring. And then if you compare this over time, then you will determine how many women will actually acquire HIV. And that is how you determine efficacy. So it is for the woman not to get infected.
All right, that makes sense. Thank you very much.
Sure. All right. So these are actually survival curves showing you how what is effective here. If you're thinking about this, it was not effective among young women, and their adherence was also not good. And it's not surprising, probably, that young women are not very loyal to using the method. But among older women, actually, it was very effective. But the 27% is driven or is influenced by what is happening for young women. But clinical trials, you need to just present one number, and subgroup analyses are something to learn from, but you can't report that. So, and of course, you have a ring available, but will the woman take it? This is another trial we did, and it was OLA or open label extension, and women did like the ring, and they actually preferred use of the ring over everything else. So, all right. I wanted to say a few words about, you must have heard about treatment for prevention. So this is the original clinical trial we did in Southern Africa. Actually, I shouldn't say Southern Africa, but we did in many countries, including Thailand, Brazil, India, and many sites from Southern Africa. Our site was one of them. We recruited actually a large group of individuals here for this study. This was called HPTN 052. This is giving antiretrovirals to discordant couples. So what happens if you gave antiretrovirals to the infected partner? Will this prevent transmission to the uninfected partner? And the data was stunning. Actually, it does, and by 96%. So this is how effective antiretrovirals are. So if you gave antiretrovirals to the person who is, I'm talking here about couples, if you gave it to the partner who is infected, and they became loyal, adherent to that regimen, then transmission will not happen to the uninfected partner. And the effect was actually 96%. So I will show you here. So the delayed is basically people who, the arm that did not receive the intervention. But the early are the people who were given the intervention. So you can see here the, and this is linked, meaning that the HIV did not happen outside this partnership. So all the sequencing was done, and it showed that actually it is the same virus between the couples, okay? So you can see here, these are linked, and the reduction you can see is substantial. This is all at any HIV transmission. You can see this is a 96%. And this is the clinical events. Clinical events were also much less in the early, those who received the antiretroviral compared to that who did not receive until the end of the trial. So this is the data that started the universal treatment, and U equals U, and treatment for prevention. So that is basically, this was the genesis of those recommendations. Let me very quickly tell you about a few things that we are doing now. We are investing heavily in long-acting injectable antiretrovirals. So the first one was the cabotegravir. And cabotegravir is an injection. It is given monthly, at least to begin with. So we provided that data, that it is actually very effective. And the most importantly, safety was not a major concern. And then now we actually have plans for lenacapavir. They are called CAB and LEN, just to avoid these long names. So with the lenacapavir, probably some of you might have been to the IS meeting in Germany earlier this year, and the study was presented there, and it showed 100% efficacy for those who received LEN. LEN is given every 6 months, so you can just imagine what the adherence will be if people were to receive an injection every 6 months, only twice a year. And it is subcutaneous. Of course, it is different from cabotegravir, which is INSTI, but the lenacapavir is capsid inhibitor. So, but it is given only twice a year, subcutaneous. There are some side effects as far as nodules at the site of the infection and so forth. But obviously, it is going to be a game changer. We are already doing the second or the third phase of cabotegravir to assess safety during pregnancy and so forth. And we have 2 or 3 studies that are planned with lenacapavir. We study comorbidities quite often. We have so many TB studies and also hepatitis B studies. And we have also we have several studies that involve broadly neutralizing antibodies, the BNAbs. Probably every scientist is talking about BNAbs these days. But just in case you are, I mean, I'm sure all of you know about immunity, and so it is one of the passive immunity where you get ready-made antibodies infusions. And then we do also behavioral studies, and I didn't include them here. So let me just show you. And then COVID came. Right now, actually, I have to give credit to my colleague, Sophia Dadabai. She is the field director of our site now in Malawi. She is resident there. So, by the way, I go there so many times during the week, during the year. But she is our resident director there, and she is actually a co-chair of this study. It is called Ubuntu study. Ubuntu in I think the Zulu word, it means humanity. So this is the biggest clinical trial, and this is where I really felt Sudan could have been included, but just there is no way to I mean, we are losing big. So let me just say it that way. But this is evaluation of the messenger RNA Moderna vaccine among individuals who are HIV infected. So data at that time showed that actually the vaccine is very effective, and we know it is very effective. Probably all of us will receive the vaccine. But how effective is it among those who have immunocompromised state? So that was the question. And this is one of the largest studies, and I think close to more than 40 sites in Africa. The study has finished the enrollment, and it is closing now. But and this was during the Omicron phase. So the rationale was basically to fill these gaps. Basically, the response among people living with HIV in settings of high HIV prevalence, like in Southern Africa. And these are the sites you can see. At that point, we were looking actually for more sites. And this is why I'm saying even we could have considered Sudan, but it was just, I will not go over these, but these are preliminary data, and the paper will come out very soon from this trial. So let me just give you briefly some ideas about the BNAB studies that we are doing in Malawi. So first of all, we started with single BNABs, the VRC01. That is the first one we did, and the safety was okay. I mean, there was no problem other than few swelling at the site of the injection. And it was very effective, actually, for sensitive viruses. As you know, there are a pool of viruses. So for those sensitive viruses, this single dose, single BNAb was very effective. So from there, we started, that was for adults, actually women, adults. And then we also did a similar study among children, and it was very good, actually. So the idea with the BNAbs is that it can cover for a long period. So you continue doing all what you have been doing with antiretrovirals and so forth, and give them also BNAbs, and I will show you where the idea is. First of all, you might hear or you might have heard about the IMPAACT 115. This is a cure program that has been going on at our site and some others. Right now, probably almost 13 years. So we are looking for HIV-infected children. You might have heard about the Mississippi baby, where the mother, for some social reasons, stopped treatment, and the baby was found to be to control HIV infection until reached, I think, 2 years or so, but unfortunately, after that, there was a rebound. So can we treat the baby very early on and therefore bring cure or remission? And cure has got different definitions. So, and during that period, how about using these BNAbs, the broadly neutralizing antibodies, basically to augment the immunity, and therefore the baby is able to control infection. So without going through the antiretrovirals. So these two trials, one is called POLS and the other is called Acacia, and we have been through battles with IRB, with the IRBs. So both of them, they have the idea of take people who are doing the viral load is controlled with antiretrovirals, and then because of this issue of adherence, how about if they have controlled state, then give them a break. So interrupt antiretrovirals and give them the BNAbs so that this is antibodies and therefore they will be covered for a period. Can that happen? So this is the concept now. And both studies, actually, we have it approved now with IRBs. It is called analytical treatment interruption, ATI. The problem is this stopping antiretroviral treatment. So the first thing, the IRBs, the community will ask you, I'm doing well with this antiretrovirals. Why are you stopping it? To see if this thing will work. A very legitimate question, obviously. However, if you can give people also some time not to take drugs, you will solve so many things. So that is the idea. And the ethical concerns were debated extensively. Actually, the good thing in Africa, in Southern Africa, is that we have community groups from different countries that are working with us. And without their help and their input and guidance, we can't do any of the work that we do. And if you ask me personally, where do I spend my time? I spend my time with the IRBs. They write me with all concerns and I write back, and that is where I spend most of my time. So both these are called ATIs, and hopefully we will see very soon. This is our site in Blantyre, a very nice place, actually. We have 3-story building that completely dedicated for research. And I managed to raise funds and build this, actually, they call it Baltimore in Malawi. Some people cynically, they say Taha Mahal. So it is a 3-story building. What do we do? These are some of my colleagues. We do research, we do training and mentoring, development of infrastructure. We have a very well-established research laboratory, 2-story building, different from this building. We can do anything other than virus culture. We do services, we provide antiretrovirals, we have clinics in the main hospital. It is called Queen Elizabeth Central Hospital, and also in health centers throughout Blantyre. And we work closely with the Ministry of Health, and our main partners are the Kamuzu University, and all the investigators are actually Malawians, internists, obstetricians, pediatricians from different fields. So all the investigators, the principal investigators who are leading these protocols are Malawians. My role is, I keep telling them, my role is to bring the money. I am the lead investigator from here. I direct the project from here, but all the people who do the work are Malawians. So we do support them, and they find great exposure, of course, publications, and they attend all our meetings. So it is a very good way of actually exposing or giving opportunities for African scientists. And we have done very well in that regard. I have trained more than 30 people for PhDs and masters, from clinical pharmacology to epidemiology, biostatistics, lab sciences. This is our building, another view, and this is the last slide I have. Sorry if it went over time, but hopefully it was of interest to you.
Thank you, Prof. Taha. On behalf of the Sudanese Infectious Disease Association, thank you sincerely for this enlightening presentation and sharing your knowledge with us today. Open the floor. I think Khalid has a question in the comment. If you can see it. His question about the nanoparticle delivery of TAT synergized with classical latency reversal agents to express HIV antigen targets.
Can you say that again, Khalid?
Khalid, can you
Yes, so I'm just asking about the nanoparticles and the promising use and like targeting the latent cell virus in the
Yes.
latent cells.
Yes. So, I mean, it is really, interesting, and it will solve many of the problems. Unfortunately, I mean, it involves so much of the basic sciences. So we are guided by others who provide. It is companies that are providing these products. So, and most of the studies actually have been done here in the US as far as safety, as far as assessment of stability of these products. So the ones we did with single the BNAbs, the single dose or single BNAbs, we did not see problems, and it seems to be working against the virus strains that are sensitive to that to these agents. However, and this is why we do clinical trials, we still yet to learn so many other aspects of these products, but they seem to be stable, and when given by infusion, it is not a problem.
I see a question from Islam and then Hamid.
Yes, thank you very much. Thank you, Prof. Taha, for the presentation and also sharing your experience of exploring experiences in Africa with all of us. And I'm just curious about the vaginal ring that you mentioned and the low utilization among younger females. And I was wondering if there were any other follow-up behavioral studies just to highlight on the whys that these young females are not using the ring when they are the most at risk population. Thank you very much.
Yes, thank you, Islam. Islam, by the way, she came from Sudan, and she's now doing her master's at Hopkins here with us. So welcome. So indeed, what you said at the end is the main factor, and that is they are a vulnerable group, and they really need a focus of research that is more specific to young individuals. And yes, indeed, we have another trial. I didn't cover it for young. I think it is 16 to 24 that we are targeting to see to learn about these barriers. So whether there are social issues and how to communicate with this younger population, it is really a challenge. And we certainly believe that is where most of the work should go as far as adolescents. But everything you said is correct. They need more targeted research and understand more. We have behavioral scientists throughout our networks here from the US, from South Africa, and from Africa as well, who are helping us with studies on young people. They are not easy, by the way, to recruit. You know why? Because there is another ministry that is involved. It is not, they are not under the rubric of health. So if you would want to do any research on, at least in Malawi, if you want to do any research on young people, then you go to the Department of Education. And and also parents are involved. Obtaining consent, it cannot be that you can get assent from the parents, but just getting consent from them directly until you reach age 18 in Malawi. Actually, women who are married at age 16 can give consent, but if they are not married, then it is 18 years. So there are certain difficulties, barriers that makes the study of young people also difficult. They also do not come for follow-up if you. So there are real issues, but absolutely what you said about that they are becoming most vulnerable is true.
Thank you very much. Thank you for the warm introduction. Appreciate it.
Hamad, it's your turn, and then Ahmed.
Thank you, Prof. Taha, for this very interesting presentation. For us, like mid-grade, actually, it's very interesting to see the history of the vertical transmission or mother-to-child transmission. And by the way, as everybody knows, this is one of the biggest achievements in HIV medicine. As Prof. Taha showed in his slide, we've seen sort of rates drop like 30% or 1 in 3 to less than 1%. I trained in Newcastle in UK, and I remember there was a lot of sort of refugees, African patients presenting at third trimester and sometimes late even at labor with HIV. So it was a nightmare to look after this sort of patients. And it was interesting to look at the sort of milestones, how things goes. My question actually, when you were testing your hypothesis regarding treating these patients, and up to now, actually, still people using zidovudine, intrapartum to prevent mother-to-child, especially if the mother wasn't fully suppressed at the time of delivery. Why you didn't test at that time combination treatment or the following sort of parenteral HIV drug to try to use like 2 drugs or 3 drugs, just as the third trimester or the intrapartum to prevent mother-to-child transmission? Thank you.
Sure, Ahmed. Everything you said is also had been our understanding. The main issue is actually logistical. First of all, we didn't have antiretrovirals, and when ACTG 076, this is the perinatal trial that tested zidovudine being used during pregnancy and then intravenously in the labor room, and then for the child. When the results of, and this was 1976, when the results of this trial came out, by the way, this regimen at the time would cost $400 US a month. So when the results of this trial came out, I personally went to the Dean of Medicine in Malawi. He was a very respected obstetrician. So I went to him and I told him that there is a new discovery and that actually perinatal transmission can be prevented by giving a drug called zidovudine. So he said, how is it given? So I told him exactly how is it given. And he said, what is the cost? And I said, so he said, Taha, 400 is more than 10 years of one person receiving care in the Ministry of Health budget. So we were not able to implement the regimen as it was originally tested. And then a group in Côte d'Ivoire, a French group, they modified, and actually CDC as well in Thailand, both of these two groups, they evaluated regimens that are much simpler, or at least simpler than the one that was proposed or tested here in the US. And they also showed, those also showed reduction. So first of all, the drugs were not available. The regimen for 076 that used zidovudine was very complicated. And until I think it was 2004 or so, is when antiretrovirals showed up in Malawi. And it was only for the elite. And some NGOs, actually, they made an effort. We made an effort as well. And then universal antiretroviral treatment was implemented in Malawi in 2016. So you can see how recent antiretroviral became available. And basically, it is PEPFAR right now. If it is not PEPFAR, we will be out of antiretrovirals even today. A colleague from Uganda, David Serwada, wrote a nice article I think, few years ago. And he challenged African governments. What will happen to you and your population if PEPFAR today, for example, withdrew? And actually, I don't know if you remember the early days of Mr. Trump. He wanted to stop PEPFAR, or at least to cut it. And he wanted to abolish also the Fogart International Center and all. So if something like that happens, you can just, I don't know what will happen for Africa. We have 40 million people who are using antiretrovirals or close to that. So what will happen to all these people? Few countries in Africa, one is Botswana. Botswana is the richest country in Africa. They have diamonds, but they have only 1 or 2 million population. And South Africa. Other than these 2 countries, I don't think any other African country will be able to provide antiretrovirals. So all what you said is correct. It makes sense. But logistically, it was not possible.
Thank you very much.
Ahmed Abu Bakr, you can ask your question.
Assalamu alaikum, everyone. Thank you, Prof. Taha, for excellent presentation. And we are really so proud of you, and we appreciate you sharing the knowledge and the experience you have gained through this year, and hopeful what you have done one day will encourage one of us to do something in our beloved country. Just one question, Prof. Taha, on the chlorhexidine use that you have you showed very clearly it reduced the neonatal and the mother sepsis and morbidity, and it is maybe the Dean and Jose can talk more on that. It is the I was wondering if that has anything to do with the removal or with the elimination of strep infection from the vaginal tract on those mothers, because what we know from the literature that the commonest cause of sepsis in neonate and mother during pregnancy is the strep infection. So I was wondering if that has anything to do, the use of chlorhexidine has anything to do with the elimination of strep infection from that area or colonization from the vaginal. And if you have done any culture before and after using of the chlorhexidine on those women.
Yes, we did a pilot study, and Izzeddin, please jump in. We did a pilot study before implementing the main clinical trial, and however, we were more interested in safety, and we did some laboratory work, but it was quite rudimentary. However, in the literature, you will find that actually it can reduce so many infections, not only streptococcus or bacterial infections, but several others, even viral. Of course, our interest was also HIV. So in the literature, it has been reported that it can be a broad spectrum for several, but we didn't do specific cultures. During the trial, it was not possible. The trial was actually a real challenge. We had 80 midwives working in the labor room, and we were working in only the main hospital. 80 midwives were covering this clinical trial. I mean, between the three shifts. So you can just imagine how, as you know, it can be quite chaotic in the labor room. So
It is.
yeah, so we didn't do cultures other than collect the samples for, and we collected the samples on dry blood spots because of the same reason. It wasn't that we wanted to collect even, for example, venous blood or so using vacuum tuners. It would have been difficult. So it is just that we didn't do specific cultures.
It's quite interesting, Prof. Taha, because see, one of the sometimes, and Izzeldin can correct me, they use antibiotics even if the woman is colonized with the strep during the labor or before the delivery, and even this might be some sort of antimicrobial stewardship approach, because if you shown that even just the chlorhexidine would lead to prevent sepsis, why you have to use amoxicillin or antibiotics, and cost and side effect and all of that to decrease the neonatal and maternal morbidity during this. Yeah, thank you very much, Prof. Taha, for that. Thanks.
Yes, thank you, Ahmed, for the good question. Just to follow up, I don't have data about the prenatal or the maternal use of this practice in Sudan. But in 2017, actually, when I visit Sudan, I visit the neonatal ICU at Soba, and also the police hospital was run by at that time by late Professor Salah Ahmed Ibrahim. So there was a very stark contrast. One of the actually registrars in Soba, she did collecting data, and about 1/3 of the neonates in Soba died of sepsis. Compared to the police, the deaths are very rare. So, and this is because of the stark, again, availability of resources. They in the police hospital, they have enough resources to do strict prevention control or infection prevention control program compared to the public hospitals, And also in Wad Madani, they have very good infection prevention control programs, and they use, actually they manufacture, or they have capability of producing their own antiseptics, and they have also lower mortality in the neonatal ICU. But this is after birth, but they have no data from HIV or other pregnancies. Yeah.
Well, thank you, Dr. Izzeldin, for giving me and for you all for giving me the opportunity. If you have any questions or you want to discuss, just to interest you, and I mentioned this to Izzeldin as well, our site is actually very open to all collaborations. You just bring the money and we'll do the work. So, I have colleagues from Hopkins and from other universities, very active collaborations from NIH and from CDC, and over the years from Europe and other places. Even now, someone from UK is trying to start study. So we have highly trained personnel. These are nurses, and this is what we are really missing in Sudan. I mean, I have someone, a nurse, who has been working with me since 1989. She came from the Ministry of Health, and she's still working with us. But they have learned all the methods of doing research, the quality control. By the way, we are monitored every 3 months by a subcontractor from NIH. So they come to our site. We even have a room for them. They inspect all the things that we do. They go to the labs, they go to the pharmacy, they go to the clinic, they see the regulatory folder and all that. So these nurses and our clinicians who are our investigators who are clinicians, they have learned how to do research in a very robust environment. Anyway, so we have the setup available. We have a lab. We have and we have a very active community group that help to so that you overcome issues of what the rumors and the ethical boundaries and things like this. So our site is open and available. If you have a good idea and you have the resources, you are very welcome to collaborate with us. And as I said, beyond the resources, we typically what we do is that we do the study not as subcontractors, but as colleagues. You will be part of it. You can go and visit. But as far as the work itself, we have data officers, we have computers, we have the physical space, we have the facilities to do laboratory testing. So it is open and it is not closed to only colleagues from Hopkins or so. So I have people who have collaborated with me from all over the world, be that from Europe or the US and within Africa. We have very active collaborations. So you are very welcome.
Thank you, Prof. Taha, for the fascinating talk. Thank you, and for sharing your experience. All right, we'll see you guys next month.